From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, and welcome to our listeners around the world. You're listening to JAMA Otolaryngology Author Interviews. I'm your host, Paul Bryson. I'm the director of the Cleveland Clinic Voice Center and section head of laryngology. Thanks for joining us. I'm delighted to be joined today by Dr. Kate Hutcheson. She is professor of head and neck surgery and chief of the section of speech pathology and audiology at the University of Texas MD Anderson Cancer Center. Welcome to the podcast, Kate.
Thanks, Dr. Bryson. Always nice to talk to you.
Well, I'm pretty excited to talk with you. You've really had a long lineage of impactful research in dysphagia and head and neck cancer survivorship. And specifically today, we're going to be talking about a recent study that's publishing. It's about manual therapy for fibrosis-related late effects of dysphagia and head and neck cancer survivorship. And it's actually a prospective pilot trial.
That's right. This is a trial we call the MANTLE trial, and it's a long time coming to get the work out to publication, as you know, and we're really excited to have the results disseminated.
If you wouldn't mind, would you give us just a brief background on you and your research interests? And then if you could, maybe put into context the scale of the problem and maybe the motivation of the study.
Yeah, sure. So I'm a clinician scientist. I clinically am a speech pathologist, and I'm in my 20th year of practice, actually all of those at MD Anderson, and specialize specifically in dysphagia and head and neck cancer and other head and neck cancer related functional outcomes. And so I guess the MANTLE trial, to put it into context of the problem is what we call late RAD, or late radiation-associated dysphagia. And this is a specific type or phenotype of dysphagia that we started studying probably about 15 years ago and really trying to develop clinical programs to help a difficult problem, as we all know, in our clinics. And this actually started with Chris Holsinger when he was with us here at Anderson. And we had a handful of shared patients and looked at each other and said, we really need to be studying this. And that came from this idea that we were seeing an increasing number of long-term survivors, and often this was long-term survivors of oropharyngeal cancers, HPV-related, who were presenting into our clinics with this very common clinical trajectory where they had enjoyed years, sometimes decades, of pretty healthy function after they had recovered from their acute toxicities of their radiation, and then presented back decades later with a substantial deterioration in swallowing. And we came to define that as late RAD, or late radiation-associated dysphagia. And we spent a lot of time just trying to characterize the problem. And MANTLE is actually our first of our prospective efforts to study interventions.
I appreciate that. As a clinician, so I've been in practice almost 15 years, and you see some things over time, right? We feel like radiation protocols have changed over time. I know you're going to get into the methodology of the study, but can you talk a little bit about radiation fibrosis? Briefly talk about the staging, and has there been a change? I know, as a clinician, we see patients that get sort of what has become standard radiation treatment, but as you looked at that landscape, what did you find?
Yeah, so radiation, as we all hear in our practice, is, the gift that keeps on giving, of course, and radiation fibrosis is perhaps the hallmark of all the late effects. My favorite characterization of radiation fibrosis comes from Michael Stubblefield, who's a PMR doc who was formerly at Sloan Kettering, now at Kessler in Jersey, and he has this elegant description of radiation fibrosis syndrome being this panacea of neuromuscular effects. It's neuro, myo, plexo, you name it, it's in there in the mechanism underlying the syndrome of radiation fibrosis syndrome, which is all of the functional manifestations that follow. And when we talk about the swallow, when we talk about the evolution of that fibrotic process toward late RAD, I have come to believe, and we have work recently funded by NCI right now looking at the premise that it's not just the muscle stiffness, it's not just the connective tissue stiffness, but there's a substantial element of denervation or lower cranial neuropathy that's also coexisting in this population. So you've got stiffness, you've got weakness, and also, of course, the sensory loss from those cranial nerves. Ultimately, you see this swallow that looks almost paralyzed, almost complete lack of pharyngeal constriction, minimal to no laryngeal vestibule closure, particularly at the level of the supraglottis. Sometimes you can see decent glottic closure, but the initial attempt at swallow clears a very small portion of the bolus into the esophagus. There's a lot of residual left behind and eventual aspiration, and that's the characteristic look of late rad. If you send these guys for GI endoscopy, often there is not a measurable stricture. If you do something like endoflip at the UES, it's usually more of a pump problem than a pipe problem. There might be a pipe problem, but it's usually mostly a pump problem.
Yeah, I like that. For those listening, I look at modified barium swallows and things like that. It's a great way to think of it like pump or pipe. And as a surgeon, the tools in the armamentarium for this are limited, right?
Right.
We'll try empiric dilation, like you said, like we're trying to fix the pipe or other things like that. So I appreciate that description.
Yeah, for sure. So we got to manual therapy because it's like, well, why did you go there? Why was that your first trial in late rad? And, you just sort of follow what you're seeing in the clinic and where the opportunities are. And so we got to manual therapy after we had started to implement, we've had a long-standing lineage of things like lymphedema therapies and the head and neck being integrated into our speech program from early work by Brad Smith, Jan Lewin, and others at our organization. And about 2015, 16, we started implementing manual therapies really into the dysphagia programs we were doing. And we were getting these patient remarks that just, it's usually those types of things that you follow into a trial. We were getting remarks where patients really felt like it made a difference. They would say, like, that's the first time I felt myself swallow in years. But we didn't know what we were actually achieving. And so we proposed a trial to the NCI and they funded it. And here we are. So that's how we came to choosing manual therapy, is that we were finding these reported benefits in our clinics, but we didn't know what we were actually accomplishing.
No, that's interesting, right? So you want to investigate what you're seeing and what you're hearing.
Right.
Yeah.
Exactly.
So what does the trial look like?
So this is a non-randomized pilot trial. So it's early level evidence, single institution, single arm. It ran through COVID, so it took forever to complete. It was interrupted by COVID at the very end. But we enrolled 24 patients who had what we called fibrosis-related late dysphagia. And essentially, patients to enroll on the trial were required to have at least grade 2, so moderate fibrosis in the neck. That was by CTCAE staging, which, if you think about it simply in the clinic, it means that there was somewhere on the neck that you couldn't pinch the skin from its underlying fascial planes, right? That's all it means. And then they also were required to concurrently have at least grade 2 dysphagia by video fluoroscopy or modified barium swallow studies. And we graded that with a method that we developed at MD Anderson called Digest. And so patients' minimum entry criteria was grade 2 dysphagia by Digest, which is moderate impairment. The reality is about 80% of patients had grade 3 or 4, which is high grade, severe or profound dysphagia on video fluoroscopy.
And then they probably filled out some patient-related, outcome measures.
Yeah.
Did they used your MDaddy?
Of course, they did it all. So at the time of enrollment, they had range of motion measured. That included cervical range of motion, how well you could extend the head upward, flexion, lateralization. They had tongue and jaw range of motion measured. They had the video fluoroscopy, of course. They had a whole host of questionnaires taken. So the LSIDS, which is a lymphedema and fibrosis specific symptom inventory that looks at symptoms both with their severity as well as how much their patients are bothered by them.
Real quick question about that. That was like my next question about the lymphedema.
Yeah.
So how often was lymphedema a part of this at entry? And then I'm hoping you'll tell me when you get into the manual therapy how this might be different than what people think of lymphedema therapy in the head and neck.
Yeah.
Because I don't know.
So this is where I need Holly McMillan, who's the lead lymphedema and manual therapist on this trial and really pioneered our manual therapy program at Anderson. I'll give it to you in my layman's non-lymphedema therapist expertise, which is lymphedema therapy. One of my favorite descriptions of the type of massage that's given in lymphedema therapy is like, it's highly directional, it's extremely light. I've heard it described as if you were like rubbing the top layer of lasagna without trying to squish the sauce. Okay. It's like
Okay. Yeah.
super light. And it's
Yeah.
highly directional because you're trying to get the lymphatic fluids draining through intact pathways, right? Whereas manual therapy is actually targeting those deeper fascial planes and trying to mobilize. So you are trying to squish the sauce, at least as I understand it. You're trying to squish the
Yeah.
sauce a little bit with manual therapies. Lymphedema therapy fundamentally is trying to move lymphatic fluid, and manual therapies, myofascial release is one of those. Manual therapies are trying to mobilize muscular structures and the, connective tissue surrounding them. And I think that's the difference. And the question about the concurrent lymphedema, I don't know the stats on it, but absolutely, absolutely there was lymphedema concurrent with some of the fibrosis, without a doubt. I don't know what the actual distribution looked like.
No, but the therapies seem different, and I appreciate that description. I can visualize it now.
You'll never look at lasagna the same,
I
right?
won't look at lasagna the same, but this is good because it helps when I talk to patients because, they ask, well, like, what is this? And so it's
Yeah,
a
exactly.
way I like to be able to try to tell stories and relate. So
Yeah.
it's helpful. So yeah, how many sessions and like what did treatment look like?
Yeah.
And then what did you find?
So patients on the trial got 6 weeks of manual therapy. We had 3 lymphedema certified speech pathologists that were conducting the therapy sessions. They had a standard protocol that was published according to a reporting guideline that's called TIDIER. And it's just intended so that when you do these, vague behavioral interventions, that you have some reproducibility. And that has been published along with the protocol for those that are interested. So they did 6 weeks of therapy. We had it intentionally titrating in frequency, thinking that you might want to mobilize more frequently in the beginning and then kind of work down to more of a maintenance. So they did 3 days a week in the first few weeks, coming down to 1 day a week by the last few weeks. The whole time they were doing some stretching at home that was guided on the protocol. And they, after the 6 weeks, moved into what we called a washout period, where they continued to do just the basic stretches at home, but didn't have the hands-on by the therapist. And that was the washout, and that was for 6 weeks. And so they did all these measures, the swallow studies and the questionnaires, and They did them at 3 time points. They did them before and after the manual therapy. And then because we wanted to, one of the biggest criticisms about things like manual therapy in this population is, yeah, you might make a change, but can you sustain it? So the washout period was designed to try to start answering that question, acknowledging that 6 weeks is not what we're looking for to sustain it, but that's what was feasible in a short pilot grant.
That's great. Yeah. So how did it go? What did you find?
It was a pilot trial. So the first thing we found was that it was feasible. That wasn't surprising to us. Patients had in our clinical practice really loved this. So more than 90% of patients finished the 6 weeks of therapy, and the adherence was quite high. And then we also found that it was safe. So we found no serious adverse events that were caused by the therapy, which was also reassuring since, you're getting deeper into the soft tissues, right? And then from the standpoint of therapeutic effectiveness, there's no control arm. So we can't say like manual therapy caused these changes, but we saw the largest changes associated with manual therapy for 2 domains. The first was cervical range of motion, and specifically extension. So if you work in this clinical population, you know that one of the cervical posture changes that you see is head drop, right? That sort of chin down toward the chest as opposed to like neck up, chest up. And so cervical extension and the other cervical planes of range of motion all improved, and they improved in really large effect size, like well above the thresholds that are considered to be meaningful. So that was really encouraging. And then the second thing that improved with large effect size was that lymphedema and fibrosis specific questionnaire. And there are like 60 items on there, and they ask a lot of questions about, soft tissue, like deep feeling of heaviness and numbness and tingling. It asks a lot of questions about perceived function, like how well can you move your neck, your tongue, your mouth. And it also asks about like function. Do you choke? Do you have difficulty swallowing, etc.? And we saw a large change in that. And specifically, when we started to tease out, we didn't publish this in this publication, but we've started to look at it out like post hoc. There were a couple items like choking that moved a large amount, which is important because we didn't see any change that was large on our swallow specific measures, things like the MDADI or digest. And so it was important that we did see some signal in the way that patients perceived that function, which we might not be measuring on our clinical studies, but they might be feeling in their day-to-day.
Yeah, I mean, it seems like such a great start because this patient group, there's not a lot of hope and they don't feel like there's things that can be tried or done. And I really applaud you and the group to explore something in a clinical space where sometimes people feel like, oh, my options are so limited and nothing will help and I can't do anything. So I don't know. This is one of those times where I think sometimes as clinicians, we look at each other and we want to give people some options. So this seems like a great start.
It does. And to your point, I think that we can, with this population, fall into the trap of saying, I don't have anything that's going to fix this, so I'm not going to do anything. And there's so much between fixing it and doing nothing. And one of the things that, as I was looking through the data and preparing for this conversation, one of the things that I had forgotten and it stuck out to me was that one of the consistent items that changed in large amounts across different questionnaires was distress and sadness. And so regardless of whether your swallow study changed, people were feeling better about living with it. And that I think we can't ignore. To me, that's always a really important component of it.
I totally agree. Well, what's next? What's on the horizon? I really appreciate you coming on the podcast today. And what are you looking to do next with this pilot information?
We've had the good fortune this year to come into some program level funding through NCI for a program of research that we call OPC Survivor that's focused on delayed side effects of oropharyngeal cancer cure. And manual therapy and fibrosis are central, as you can imagine. In that program of research, we have a potpourri of projects that are targeting dysphagia, radionecrosis of the mandible, and cranial neuropathies. And we're looking at earlier identification of when nerves are beginning to lose function and implementation of some manual therapies in that early subclinical phase because of some preclinical data on hypoglossal nerve injury and manual therapies that we found interesting. So that's one place that manual therapy is being pulled in a little bit earlier in the trajectory for patients. When we're talking about those folks who've already gotten to the point of clinical demonstration of deteriorating sort of catastrophic functional loss, the one thing that we're doing in our clinics is trying to figure out how to best integrate and iterate the manual therapies with other more conventional swallow specific, like bolus-driven therapies, like we love McNeil dysphagia therapy and different exercises. Like if you're mobilizing these soft tissues, are you priming the patient to more effectively engage in some of these other therapies? And if we layered those, would it be more effective? Would we see differences in those swallowing measures that we didn't see in the manual therapy trial where we were only doing mobilization? So that's sort of the practical clinical step that we're taking with it. But just a lot of opportunity to get in and use the manual therapy earlier and then to integrate it with other therapies when you're later in that game.
Well, I always love to see what you and your group are working on down there. So I just thank you for coming on to the pod.
Yeah, thanks so much for having me. I always enjoy it.
I'm Dr. Paul Bryson, and I've been speaking with Dr. Kate Hutcheson about manual therapy in fibrosis after radiation therapy for head and neck cancer. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.